Welcome to our final seminar of the University Seminar Series with the GW Institute for Brain Health and Dementia on addressing dementia across public health spectrum. So it's my pleasure to welcome Dr. Zissimopoulos, who is a professor in the Sol Price School of Public Policy at the University of Southern California. In addition to her faculty appointment, she is Senior Fellow and Director of the Aging and Cognition Research Program and Research Training at the Schaefer Center for Public Health Policy and Economics. She is director of USC's Resource Center for Minority Aging Research and Center for Advancing Sociodemographic and Economic Study of Alzheimer's Disease and Related Dementias, both focused on reducing burden of Alzheimer's disease and funded by the National Institute on Aging. Dr. Zissimopoulos' current research focuses on economic costs of dementia, impacts of dementia on care partners, the use of and response to drug therapies for non-dementia conditions that influence risk of dementia, racial and ethnic disparities in diagnosis and healthcare treatment for dementia, and population measures of dementia using Medicare claims and survey data. So let's please give a great welcome to Dr. Zissimopoulos.
Thank you, Keith, and thank you to you and Melinda for the invitation to join you. Let me share my screen. And then I will get going. Okay. So one more moment. Okay, so again, thank you. And I'm really pleased to be here. I've had the opportunity to listen to several talks from the seminar series and have learned a lot. And I'm really happy to have the opportunity to present to you today. I'm hoping to add to the series a health policy and economics perspective, talking about opportunities for slowing development of dementia, reducing its social and economic impacts, and thinking about dementia health equity. And my approach is going to be through examples of research that colleagues and I have been working on. So with that, I'm going to start by introducing my multidisciplinary team. We're economists, health policy researchers, data analysts, and students of health policy and economics. And the team, importantly, also includes, and they're not shown in the photo, many collaborators from across USC and outside of USC from the basic and clinical sciences. So here's a list of some questions that we are addressing around risk, dementia diagnosis and care, health equity and care, and how today and the future, COVID-19 and innovation in Alzheimer's disease treatments are going to be impacting dementia. And I'm going to organize the talk around research that addresses these questions. For our research, we primarily use national survey and administrative claims data. So I want to just take a few moments at the beginning here to introduce to you a few points about these data sources. So this table describes different data types. It's not meant to be comprehensive, but illustrative. Most commonly used for health policy and economics and our research are administrative claims data and nationally representative data sources like Health and Retirement Study and the Understanding America Study. So I'm just going to make a couple comments quickly about each one of those. So Medicare claims data. There are 65 million US adults enrolled in Medicare. So key strength of these data for this types of research are obviously the large population of older adults, and they're followed from the time they become Medicare beneficiaries at 65 to the date of death. There's also very large samples of racial and ethnic populations, and their measures of healthcare use are not subject to biases that we know are prevalent in self-reports. Dementia is based on a diagnosed dementia, and I will return to this issue and limitations and way we deal with this in just a moment. Another key point is that the purpose of these data, of course, are for billing and payment. So there are limited other measures, socioeconomic status measures. But that said, there are opportunities to link these kinds of measures through the zip codes of the beneficiaries. The other source that are commonly used and that I will talk about today are nationally representative studies like the Health and Retirement Study. And importantly, the study has really innovated in the area of measuring mild cognitive impairment in dementia through its HCAP, Harmonized Cognitive Assessment Protocol measure. And so when you combine it with the other measures in the survey, you have great opportunities to study social and economic determinants of health and dementia. There's some limitations around small sample sizes of some racial and ethnic populations. And then, of course, you can link these data sources for sort of strengths of both. So this first research question addresses pathways to dementia risk. And I put this life course model just pretty much to highlight that there are both these individual pathways, and then there's also these systemic and contextual factors. And then along the x-axis is the life course perspective. So I wanted to point out particularly the economic and healthcare pathway as the second example that I'm going to talk about is going to refer to this pathway. But first, I want to start with an example by my colleague at USC, Eileen Crimmins. And in this study, they compare the relative contributions of genetic, biological, demographic, and social factors to cognitive function or dysfunction, as you see in that third bar from the top. And they do it using a cross-section of the health and retirement study. And what I found very interesting about this study is thinking about how much of the variation across individuals is explained. And you can see here that it's only about 25%. And genetics and biology are actually less than 5%. So the data suggests that when we put the biological and genetic information with our other measures, it's a useful tool to predict health outcomes in life. But other factors such as demographic, socioeconomic status, mental health, and health behaviors remain very robust predictors of cognitive dysfunction. So the next example I want to focus on is pathways to dementia risk via drug therapies for non-ADRD, non-dementia conditions. And this is a clinical pathway, but it's a pathway that's highly influenced by health policy because the drug therapies that are utilized for these other health conditions and individuals' adherence to them are affected by health insurance benefit design. So what drugs are covered by health plans, drugs cost, and also physician preferences. We've been publishing several studies in this area, and I'm going to just focus on one. But before I turn to the study, I wanted to begin with an overview of the way we approached this area of study. And we started with convening a panel of experts from the clinical basic and pharmaceutical sciences. And this was really to help us identify and prioritize drugs for study. So those that are hypothesized to reduce dementia risk, like statins and antihypertensives and antidiabetics, anticoagulants, but also those that are hypothesized to increase risk, such as antispasmodics and benzodiazepines. So we started with a scoping review that included 29 different drug classes, and we combined 400 studies. But what was very notable from these studies, human studies, were a lack of analysis by sex and race, so the heterogeneity in effects. So the way that we approached the design of the study is that we looked at the drug's hypothesized mechanism of action, both on the pathology of AD and other dementias, and then also through the effect of the targeted disease. So for example, antihypertensive therapeutics reduce hypertension, and hypertension is a risk factor for dementia. And then we took these hypotheses to our Medicare claims data, where we can really look at the heterogeneity in effect, and we can follow people over time, so following their drug use, and for those who are dementia-free, the onset of dementia. As I alerted to earlier, a limitation of these data are the use of diagnosis codes to identify persons with dementia. So we do the best we can with this limitation by using an algorithm. And so we use dementia diagnosis codes across all healthcare settings, and we also include Part D drug codes for drugs that treat the symptoms of dementia, which we found are very important for picking up non-white populations in our coding of dementia. We also use codes for MCI, and symptoms such as aphasia, agnosia, apraxia, but the latter are only used in combination with a dementia diagnosis for verification and for timing. And then we track codes over time and require a second coding in order to exclude any rule out diagnoses of dementia. So in the study that I want to talk about, we analyzed different antihypertensive medications for insight into how we might approach population risk of Alzheimer's disease through thinking about what type of antihypertensives and for whom. So thinking about it from a personalized medicine approach. Antihypertensives are one of the more well-studied and thought about treatments for dementia. 75% of older adults have hypertension, and almost all of them are treated with antihypertensive medication. But the medications that they're treated with are not all the same. So in particular, there are those that act on the renin-angiotensin system. I'm going to call them RAS-acting medications. And these are your ACE inhibitors and your ARBs. And they modulate numerous protective mechanisms against Alzheimer's disease independent of blood pressure effects. And this hypothesis is based on studies by our collaborator on this study, Pat Kehoe. And secondly, while both ARBs and ACE, these RAS-acting antihypertensives, are hypothesized to be more protective than the non-RAS-acting drugs like the calcium channel blockers and diuretics, ARBs are thought to be more protective than ACE inhibitors. So they act on the same system, but in different ways. And again, we're drawing on a long history of work by our collaborator, Pat Kehoe. And then finally, these RAS-acting agents are believed to function differently in Blacks compared to whites due to higher endogenous sodium and lower renin levels in African Americans. So we take these hypotheses and we go to our Medicare claims, parts A, B, and D data to test them. So what we have is a study population of antihypertensive users. And what this table is showing is the odds ratio of Alzheimer's disease risk, so the onset of Alzheimer's disease, for RAS-acting drugs, so the users of those drugs relative to the non-RAS-acting drug users. And what we find is that the RAS-acting antihypertensives, as we hypothesized, were significantly associated with reduced risk, but not across all categories for males, but not for females overall. And when we look across race, we can see that the association was largely driven by white males. So we look then to our second hypothesis, comparing ACE and ARBs to the non-RAS acting. And again, testing that hypothesis, we found that the protective effect of these RAS acting antihypertensives were driven by the ARBs, not the ACE inhibitors. So there was no significant association with reduced Alzheimer's disease risk for ACE relative to non-RAS acting, those calcium channel blockers and diuretics, regardless of sex and across race and ethnicities. And again, there's heterogeneity. So the ARB use was associated with reduced risk for white females, Black females, and white males. And what's, I think, notable is this effect for Black females, because historically, ARBs have not been the first line of defense or the first line of treatment for hypertension for African American and Black persons. So of course, these types of real-world data studies require replication and follow-up, but it points to the way of thinking about how we might approach these population disparities through thinking about what types of antihypertension medications are used and for whom. So I want to move on now to question 2, which is really looking about how insurance design impacts dementia diagnosis and care in the US and across diverse populations. So our first study is really focused on thinking about the differences between beneficiaries in Medicare Advantage and traditional Medicare. So there, as I mentioned at the beginning, 65 million adults enrolled in Medicare. Today, there's about a half in traditional Medicare and a half in Medicare Advantage. So those private plans that must follow the rules set up by Medicare, but they also often have other benefits and include drug coverage. You can see here on the graph that when myself and my research colleagues were beginning to study different aspects of dementia, we used traditional Medicare, claims from traditional Medicare, and that was fine because back in the early 2000s, there were very few beneficiaries enrolled in Medicare Advantage. But now, given that there are half of beneficiaries, it's important to consider these beneficiaries and how their care and detection might be different, which was not possible until most recently. CMS did not release data from Medicare Advantage plans, but now they do release the data, so researchers can access them and ask these types of questions. Besides half being in Medicare Advantage plans, they're disproportionately non-white. So when we're thinking about health equity, thinking about beneficiaries in Medicare Advantage is also important. So why might diagnosis and care be different? Well, there are definitely different incentives for detection of diseases and care in Medicare Advantage. So first of all, Medicare Advantage plans are paid at a risk-adjusted per member per month fee. So they have a stronger incentive to coordinate care, stronger incentive to code diagnoses since they're paid based on the population health. And they also have incentives to control costs by limiting care, although there are these quality metrics that act against this incentive to reduce care. In contrast, in traditional Medicare, as we're more familiar with, there are very few explicit constraints on care seeking, but beneficiaries can face high out-of-pocket costs. There are weaker incentives to reduce unnecessary care or to coordinate care, and access to specialists may be better than in Medicare Advantage, although that's not 100% clear. So given these differences, we started by examining rates of diagnosed dementia in Medicare Advantage and traditional Medicare. But because the demographics and health are different across the population enrolled in these two types of Medicare, so the beneficiaries in Medicare Advantage tend to be younger, as I mentioned, more likely to be from underrepresented racial and ethnic groups. We first adjust for these differences in the beneficiary population health and demographics. And we actually found that the prevalence of a diagnosed dementia was higher in traditional Medicare, 8.7 compared to 7.1 in Medicare Advantage. When we looked across race and ethnicity, we also found the same pattern hold across white, Blacks, Hispanics, Asian, and American Indian Alaska Natives, with some particularly striking differences among Black persons in traditional Medicare. So thinking about going forward, it'll be very important to track the diagnosing of dementia over time, because in 2020, CMS reintroduced the Alzheimer's disease and related dementia risk adjustment. So there now again is an increased incentive for plans, Advantage plans, to better detect and record dementia diagnoses. So whether they are better at detecting previously undetected, or if it leads to unintended diagnosing practices, will be an important research question to consider going forward. So just to give you a sense of this diagnosed dementia versus other measures, we combined the rates of diagnosed dementia among beneficiaries in the Advantage plans and traditional Medicare. So now we have 100% of all Medicare beneficiaries, everybody, and we wait for who's in which one. And in this graph, we look at prevalence rates based on these diagnosed dementia, and we're comparing it to dementia prevalence rates based on this Health and Retirement Studies new harmonized cognitive assessment protocol, the HCAP, that is reported in a pretty recent study by Manley et al. So those are those dark bars. And overall, what we found was that diagnosed dementia is about 8%, while dementia based on the HCAP measure is 10%. So about 2 percentage points lower, or 20% of the population is not diagnosed. So this is a significant proportion, but it is far less than prior estimates. We also confirmed prior findings that undiagnosed dementia is larger among Blacks. However, interestingly, we do not find any differences among Hispanics. And what we can look at in diagnosed dementia is prevalence rates for other groups that are harder to measure at the population level and are not available to measure in the health and retirement study, which are Asians and American Indians, Alaska Natives. And you can see here that we find prevalence rates of 6.7 and 8%. And we are able to compare the rate among American Indian Alaska Natives to another recent study using the NHATS, which found a 9% prevalence among that group. But again, study in these particular groups are definitely much more is needed here. So turning now to the differences in care in Medicare Advantage and traditional Medicare in the months leading up to a dementia diagnosis and after. So what we did here was we analyzed Medicare claims and encounter data, so for traditional Medicare and Medicare Advantage from 2015 to 2018. And we compared monthly hospitalization rates and outpatient visits 12 months before an incident dementia diagnosis and the 12 months after. So what you're seeing in the graph on the y-axis is the adjusted difference in care use in traditional Medicare compared to Medicare Advantage. So above 0 means that more care is in traditional Medicare, or more care is used by those beneficiaries in traditional Medicare. So looking at the left-hand side, what we see is in the 12 to 6 months before a dementia diagnosis, the likelihood of hospitalization was about the same for beneficiaries in MA and TM. In the month of diagnosis, 36.5% of beneficiaries in traditional Medicare had a hospitalization compared to 25% in Medicare Advantage. So you see that 10 percentage points difference in that graph that shows more likely for beneficiaries in traditional Medicare. And then that difference persists after. So more hospitalizations among beneficiaries in traditional Medicare. And then if we look at the right-hand side, that's the number of outpatient visits, and the pattern is more or less the same. So more healthcare use, hospitalizations, and outpatient visits among beneficiaries in traditional Medicare, adjusting for lots and lots of differences across the beneficiaries. So more in traditional Medicare compared to Advantage. So that's interesting. It's kind of important to think about in respect to the incentives that might be driving this. But what we really want to know is, does it matter? Does it matter for persons with dementia, whether they're getting more or less care? And so one outcome, or one why do we get care we can look at, is mortality risk. So what we do next is look at how this care differences in Medicare Advantage versus traditional Medicare among persons diagnosed with dementia. What's its impact on 1-year mortality risk? And what you see here is that indeed the adjusted odds of death within 1 year are actually slightly higher for beneficiaries in traditional Medicare. So those who are using more healthcare, controlling for just about everything you can think of. So we don't find that reduction in use or the limits in healthcare use is leading to higher mortality risk among persons in dementia, with dementia and Medicare Advantage. So now I want to talk a little bit about improving early detection and diagnosis. So it's very clear that there's no national screening program for cognitive impairment or dementia, and the U.S. Preventative Task Force has continued to conclude that evidence is lacking for one. However, the Patient Protection and Affordable Care Act in 2010 provided a new benefit for Medicare beneficiaries, the annual wellness visit. And that started in 2011. So what the ACA mandated was that the annual wellness visit, AWV, include detection of cognitive impairment annually, along with a lot of other health checks, blood pressure, weight, medical history, and other routine services. So this annual wellness visit has the potential to better detect cognitive impairment and thus increase dementia diagnoses, so reduce that undiagnosed rate. But there are considerable barriers, including, but definitely not limited to, guidance on how this cognitive assessment should be done in primary care during an annual wellness visit. So there's not much guidance. There's no requirement to use a validated or standardized tool. And there really is not a clear pathway for a primary care physician to make the detection and then know what to do next with it. So with this, we wanted to look at this relationship between the annual wellness visit and detection of diagnosed dementia. So let me just give you a little bit more of a background on the annual wellness visit. When it was first introduced, it wasn't used very much by Medicare beneficiaries besides, which is a little surprising, it's a preventative healthcare check that was never before reimbursed, and now you could get to it annually. But over time, the percent of beneficiaries getting an AWV has increased, and you can see that in the graph here. But against this backdrop, there are a few methodological challenges to understanding that association between having an annual wellness visit and increase in that annual wellness visit, that policy change increasing dementia diagnoses. So the first is that the correlation between incident dementia diagnoses and annual wellness visit is negative. So incidence has been declining and the annual wellness visit is increasing. So this unadjusted negative correlation. And really importantly is that the people who get annual wellness visits don't look like those who do not get an annual wellness visit. So if you look at this table on the left, you can see that persons who are getting an annual wellness visit are younger, they have higher socioeconomic status as measured by their dual eligibility status. They're more likely to be white. So when we run ordinary least squares models of this relationship, adjusting for health, dual eligibility status, demographics, etc., the negative correlation is reversed, and we find no effect, zero effect of the annual wellness visit, this policy change on detection of diagnoses. But again, we have methodological issues of unobserved differences. So we utilize an instrumental variables approach where our instrument is a county level change in AWV. So across counties, the rate of increase of beneficiaries getting annual wellness visit is highly variable. And when we use this instrumental variables approach, we find a small impact of annual wellness visits on dementia diagnoses with some notable differences across race and ethnicity. So the effect is only positive for whites and Blacks, and there's no effect among Hispanics and Asian persons. But you can see that the effect size is much larger for Blacks than for whites. So really trying to unpack this black box of the annual wellness visit and how and why it may or may not improve detection of dementia is still a very large and I think highly unexplored research area. So I'm going to move on now to question 4. So we have been looking more recently at dementia care during the pandemic. And so more specifically, we have been examining care received by persons living with dementia after a COVID infection diagnosis compared to matched persons without dementia. And so here again, we're using Medicare claims data in 20 and 21. And what we found is that persons with dementia across all different races, shown on the left, experienced worse outcomes after a COVID-19 infection than matched persons without dementia. So specifically, they experienced higher mortality within 30 days of a COVID diagnosis and higher mortality within 30 days of severe COVID infection. So COVID infection that led to hospitalization. And again, I'm going to point to where I think there's a lot of work to do, which is the why. What are the multifaceted reasons why, adjusting for all sorts of other aspects of their health, their outcomes were much worse. So is it the care environment? Is it their ability to access healthcare, et cetera, et cetera? And then from there, what we've been working on is the lasting effects of a COVID-19 infection. So there's been a lot of studies suggesting that COVID infection causes neuroinflammation, via brain immune cells, but also by the virus entering the brain. There's also been studies that show it damages blood vessels and the lining of blood vessels that lead to stroke. So what we looked at was incident diagnosis in dementia in 2021 among older persons who had a COVID infection in 2020. And what the graph shows is incident dementia over time, so prior to the pandemic. And what is very clear is that incident diagnosed dementia has been slowly declining, and that's consistent with other measures of incident dementia, not using claims and diagnosed over time. And so what you see in this line is we kind of predict out the time trend in incident dementia diagnosis through 2020 and 2021 in the absence of a pandemic. And we compare that to the line that you see in orange, 3.6 to 4.9, which shows the actual incident dementia diagnoses in 2021, 5%. So this is almost 1.5 percentage points higher than we would have predicted in the absence of a pandemic. And on a base of 3.5%, this is a 42% increase in dementia. So we can also look at that by race and ethnicity, and that pattern is consistent across race and ethnicity. So while the higher rates of diagnosed dementia may be due directly to the COVID-19 infection, it also could be due to delayed healthcare, which we know was a big issue during the pandemic. So what we then looked at was stroke. So you can argue that stroke is unlikely to be delayed healthcare given the urgency of a stroke. And again, what we look at here is the rates of stroke. So the kind of flat rates of stroke, 2016 to 2019, and then following the red line, we see incident stroke increase in 2020 and 2021, 2.9 and 3.6. And then severe COVID infections were associated with incident stroke of 3.4% of the population in 2020 and 4.3 in 2021. So we see this kind of long arm of COVID impacting stroke and dementia in the population. And again, these differences persist across race and ethnicity, and are particularly high among Blacks and African Americans. So I want to end with a focus on future health and healthcare costs of the population. And I'm going to kind of briefly introduce a dynamic microsimulation model that we have been developing over decades at the Schaefer Center, which the point of it is to help us understand the population impacts of changing health trends, changing medical technology, changes in policy on public health. And I'm going to focus on Alzheimer's disease and dementia for this example. But first, I'm just going to kind of briefly introduce at a very high level what this model is and what it does. So the model uses longitudinal data from the Health and Retirement Study. So it's a nationally represented data source for middle-aged and older Americans. And what we do is we model how these middle-aged and older Americans age. So we use a rich set of risk factors, health, social, economic, and demographic factors associated with the onset of different diseases, such as hypertension, diabetes, and dementia. And we estimate these same factors and how they affect mortality. And this is a real kind of unique feature of this simulation model in that we actually model mortality, whereas a lot of simulation models use age-specific life tables. So the other key point of it is that we account for these competing risks of disease on, for example, dementia and mortality, their correlations. And then we quantify at the population level the prevalence of disease. We can use data from the MCBS and the MAPS to measure healthcare costs for each individual, and then we aggregate it to the population. And then with this, we can simulate future prevalence of disease. And important for this is that at each time point, we have new cohorts of 51-year-olds, middle-aged Americans entering the model. And those populations reflect the health trends that we see using data like the NHIS and NHANES. So the prevalence of diseases for these younger cohorts as they age into the simulation. So for example, younger cohorts tend to smoke less, but they have higher BMI, more prevalence of diabetes, and hypertension is higher. So it's sort of like a high level view of what this model is. And then I want to talk about one thing that we do with that, which is we model Alzheimer's disease prevalence and costs into the future. And we can use it to compare to what if scenarios. So what if population health changes? What if, and an example I'm going to give is what if there is a medical innovation that can delay the onset of Alzheimer's disease by 5 years. So no cure, it's just a treatment that delays the onset of the symptoms of Alzheimer's disease. And so when we compare this status quo, no change, to this hypothetical innovation, what we find, and kind of looking at that top left graph there, is that over time, from 2010 to 2050, we see the population of persons with Alzheimer's disease more than doubles to 9.1 million in 2050. And then what the blue line below is showing you is that with this hypothetical innovation, so this delay in the onset of Alzheimer's disease at the population level, we can reduce the number of Americans, older Americans, by 41% in 2050 to 5.4 million. And then what we also do with our model is look at the costs associated. So the costs that we are calculating here are medical care costs, long-term care costs, and the value of time provided by unpaid family caregivers. And what you see on that right top graph is in 2050, without any new treatments, the cost will be 1.6 billion. And to put that number in context, it is higher than the costs associated with cancer and heart disease combined. With this innovation, this hypothetical innovations, costs are reduced in 2050 by 640 billion. Another way of thinking about a value is we can take it from the individual perspective, a social value, and ask, what is the lifetime value to an individual from these additional Alzheimer's disease-free years that they get when their Alzheimer's disease is delayed by 5 years? And we value that at 475,000. So moving on, the hypothetical, we're not there yet, but what we're doing now is using the model to quantify the impact of lecanemab. So brand name Leqembi, the currently approved treatment that is under accelerated approval. So it's only reimbursed by Medicare under coverage with evidence development. So for those in clinical trials. And so I just want to briefly talk about sort of how we're modeling this value of lecanemab. And basically, this figure is sort of gives you the overview of our study approach. So we use the data that are reported out from the Clarity AD trial on the delay in cognitive decline and functional status decline. And we take a subset of the HRS respondents that are adjusted to look like the clinical trial cohort, because obviously nationally representative samples don't look like your clinical trial cohort. And then we model these changes in the clinical dementia rating, sum of boxes. So that's the outcome from the clinical trial. And to do that transition model, those changes in cognitive status, or CDR-SB, we use data from the Alzheimer's Disease Neuroimaging Initiative. And so we find people that look like those clinical trial cohorts. So they have a CDR of 0.5 or 1, so mild impairment, and positive amyloid beta. And then we intervene, use our model to mimic this intervention of the trial And so we can calculate this treatment effect on other things that we might want to know. So how it affects formal medical costs, how it affects nursing home entry, how it affects the time that unpaid family care for persons, and then also the quality of life using the HUE-3, and we translate that to dollars. And then another important thing that we do is we value it assuming that this effect persists over 3 years. So the trial was 18 months. We carry that out to 36 months. And so the bottom line is that our model estimates a $20,000 3-year value of the current treatment and its current efficacy. And this is the gains in quality of life and lower costs associated with less care needs. But I don't necessarily want to dwell right now on whether this is a big enough value or not. What I want to talk about is going back to sort of health policy and, whether it's lecanemab or some other treatment coming down the pipeline with higher efficacy, lower side effects, none of these treatments will add value to individuals or the population if they continue to be barriers. And so I want to talk a little bit about the barriers that we've been studying and what we know something about. Of course, one of the biggest barriers will be cost, and this will depend a large part on reimbursement by CMS, but also private payers. So currently, reimbursement is only for those in clinical trials by CMS. Medicaid in some states, I think just a handful of states, and the VA is covering treatment. And then so cost will be an important barrier. And then second, current treatments are targeted at patients with MCI or early stage disease and that are amyloid beta positive. So early detection will be very important for the population and individuals to actually gain value from these treatments. So we, again, looked at this cognitive assessment. So how well do we think we're doing in terms of picking up persons at mild cognitive impairment and early stage disease? And because this is not easily information that you can get, we conducted a survey in the Understanding America study to quantify rates of persons getting cognitive assessment, which is an important first step towards detection and diagnoses. And I guess what we found was a bit discouraging. Only about 26% of older adults had a cognitive assessment at the annual wellness visit, a little bit higher among those in Medicare Advantage. And still well under half had a cognitive assessment at any visit. So we kind of distinguish between those two because the annual wellness is annual, which is a good way of detecting changes and declines versus this, have you ever had one? And then we also conducted another study to learn about other impediments to early detection, which again will be very important in order to have access to treatments. And in this study, we used a vignette design. Again, we used the Understanding America study. And in the vignette study, we asked respondents, it's an online panel study, to read different scenarios that describe symptoms from normal aging to MCI to dementia. And then we asked them if, given that vignette of symptoms, if one should follow up with a healthcare provider. And importantly, we randomized respondents to receiving vignettes that described the symptoms that are pertaining to another person of their age, or as describing the symptoms pertaining to themselves. And so the good news was that most respondents identified the symptoms of dementia and that they needed a follow-up visit. So 95% recognized the symptoms as needing a follow-up visit by a healthcare professional. But that was when the vignette was stated as another person of about their age. And this declined to 84% for that randomized group where the vignette said the symptoms were one's own. So what this sort of indicated, so this is 10 percentage points less. So what this told us was that, knowledge is definitely improving. So what's normal aging, what's dementia, that seems to be at a population level to have improved dramatically over time. But these other barriers, whether they be stigma, denial, or trust in the medical system, are going to be important to address if persons who want to have access do access these treatments. And then just kind of looking into the future, there's really great momentum building for the impact of research generally to inform risk and find opportunities to improve the lives of persons living with dementia and their families. And there are some really interesting and important health policy and economic research areas that are emerging because of changes to things such as benefit design and reimbursement, how we detect Alzheimer's disease, for example, through blood-based biomarkers. I talked about the current treatment that a lot of people are talking about, lecanemab, but there are many more treatments in the pipeline. And we have coordinated care models that are being developed and now are being tested and considered for their likeliness of dissemination. So there are a lot of research needs. And I just wanted to end by inviting you to connect with me either through one of the centers, and the centers provide pilot funding and have lots of resources that if they're useful for you, I would be very happy to connect with you about. And then I also want to acknowledge several of my research collaborators. So with that, I will stop my share and invite questions. I know that was kind of a large and quick view through many things, but I hope to hear from any of you, any questions or comments.
Thank you. That was a lot of really great information. So I'll start with the first question. I think you did mention this, but I just want to clarify. So when you say dementia, is that the full range of dementia, like mild to severe? And does that include mild cognitive impairment as well?
So in a lot of our studies, we are looking at the range of dementia. When I specifically said Alzheimer's disease, that was when we tried to pick out Alzheimer's. Otherwise, it's dementia. It really depended on what study we were looking at, whether it encompassed mild cognitive impairment. I mean, one thing that I can say is the studies that use claims, we use the algorithm that we use with dementia and mild cognitive impairment. Mild cognitive impairment is very underdiagnosed in claims data. So I consider that picking up persons with diagnosed dementia specifically.
And just kind of a piggyback on that, then if you're sorry. Go.
I was just going to make one other comment, which is the model that I mentioned. Now we have kind of further developed to use the CDR sum of boxes to stage dementia. So more able to address I think what you were thinking about, which is the different staging and the associated costs or healthcare use. So we're working in that direction.
That's wonderful. Thank you.
Any other questions or comments? I'd love to hear from you about your own research too. Paula?
Hi, I was just curious, I'm not sure if you may have stated, but as far as people like getting diagnosed, is it just overall, like you see a primary care physician, how would they, because I know I don't think they diagnose just anybody. So it's almost kind of like they have to pick up on something that maybe cues them like this person needs to get screened for it. Because I'm wondering if they don't screen everybody, I wonder if like people who have like a family history of Alzheimer's or dementia, if maybe because of stigma within their community, maybe they don't talk about their medical history. And so maybe that puts them at risk for possibly like maybe getting more advanced cases of Alzheimer's later on.
Yeah, so we try to look at that a bit by linking claims data with survey data from the HRS, where we can stage dementia in a rough way, but and basically what we found was, I think, consistent with what you were alluding to, which is that persons with lower education and racial and ethnic minority groups tend to get diagnosed at what seem to be later stages, so more severe according to the survey measures of cognition. Does that answer your question, Paula?
Yes, thank you.
Just ask another question. So I found it really interesting, looking at, the effect of different blood pressure medications. Are you able to somehow kind of look at adherence to taking these medications, like through whether or not they've actually filled the prescription and how often they do that?
Yes, thanks, Keith. So adherence is a way in which we measure use. And so our approach to kind of keep this study focused, keep our apples to apples comparison, is we consider the same level of adherence, so pretty high adherence when we're looking across antihypertensives. But one common approach across these studies that we work on is when we kind of change that, what we call a user. So we change that, what we call adherence. So as you alluded to, in claims, what we can see is the number of fill days. So did they fill for 365 of 365 days, or some lower threshold? So it's often referred to in the literature as the medication possession ratio, because we don't see that they take the pill, but we see that they fill it. So we keep that kind of constant when we're looking across drugs, but then we try to examine whether our results are sensitive, or at what level are they sensitive to adherence.
Great, that's great. Thank you.
I guess the other thing I will mention, since I have a group here, is that I welcomed you to connect to us, but I also want to kind of implore you to think about like how your own research could benefit from some of the resources we have at the center. So things like this tool, we encourage and try to support use by other people. So you don't have to learn how to code everything on the tool, but if you have an idea about, oh, I've been studying this, I would like to look and see what are the population impacts. We have programmers that can work with you, and we usually do this through pilot grant funding to ask and answer those questions. So you bring in your expertise on policy or a health trend or an innovation, and then we support the use of the tool. So I just want to kind of put that out there and maybe inspire other people to think about how their research might progress or go in a different direction if they're thinking about the future. Lawrence?
Hi, great talk. Learned a lot. My question is, how is dementia or Alzheimer's typically diagnosed? Is it a screening questionnaire that patients are scored on, or is it really a blood test and then we look at certain measures, and then are the measures continuous or discrete that we use to classify whether someone has dementia or not, and then what kind of treatment they should get?
Those are all very good questions. Let me see what I can tell you based on like what we can see. And then, for my own research, I work with a neurologist and in primary care physicians to provide additional insights. So one thing that we know is that 85% of persons are diagnosed by like what I'll call non-specialists, so family internal medicine. And the other 15% by what we call specialists. So these might be geriatricians, neurologists, in the psychiatric field. And so there are probably very different approaches to how they're diagnosed depending on who is diagnosing. One of the, I think, sort of important areas that we're looking at is this how are they diagnosed in primary care? And as I mentioned in the annual wellness visit from claims data, it's a black hole. Like, we don't know what happened. But in the survey, we got a little bit of insight into that just by asking people, was it, a structured mini med, we kind of described what that looks like, or an ADCOG, one of these validated structural versus do you feel like you're having any issues with your memory? That sort of question. So I think there is a lot of work to be done in that area, both understanding better what actually happens, and then sort of pushing forward on better ways of detecting in primary care. And there's a lot of, I think, great researchers working in this area, and it's super important. And then there's that whole area that people are working on, where can we use algorithms to, in the background, help physicians identify high-risk people, and then they can focus these assessments on those persons. So it's a really active and super interesting research area.
Thank you. Okay, I have one more question, I guess, if no one else. So I was intrigued by the microsimulation model. Did you backtest the model to establish, how well the model performed in the years that you have already the outcomes for?
Yeah, so we, as I mentioned, it's been developed over decades. We do a lot of validation. We have an entire team here directed by Brian Teisinger, who spends a lot of time validating, putting uncertainty around our estimates. Mm-hmm. And there is, if you go to the Schaefer Center's health policy website, you can link to like technical documentation and some details about that. But it is very important to validate these models. And the other thing that we're doing is building out modelers, these teams of modelers, so that there's not just one model, but there's lots of models, and we can compare and think about doing it different ways. So we're part of a larger consortium that focuses on improving these models for use.
Great stuff. Thank you.
Thank you for your questions. Appreciate it.
We have a quiet group today.
I hope I didn't put too much on the table there and quiet the group.
This is wonderful, yeah. Especially the model at the end that really ties it together nicely to show what a huge effect, just intervening early does. My mind is blown. I'll definitely contact you later about some ideas.
Oh, great.
But seeing it's the top of the hour, thank you very much for all that wonderful information. And thank you for kind of rounding out our seminar series with a final seminar for this year. And thank you everybody for attending the past 2 years of the seminar series that we've had. And we hope to have more in the future. So thank you very much, Dr. Zissimopoulos. Is it Zissimopoulos?
Call me Julie.
Julie.